let us see what are cracks and fractures in the endodontic scenario. See, crack, as the name indicates, they are incomplete form of tooth structure defect, and fractures. What are cracks and fractures? And fractures, they are the complete form of tooth structure defects. Okay, through and through defect is known as fracture. These cracks can sometimes be limited to only the enamel, or they can be extending to enamel and dentine both. Okay. When they are only limited to the enamel, these incomplete structures, they are called graze lines. You must have seen graze lines in some patients or in some people when light is reflected from an oblique direction. Fine radiopaque lines are observed, which are graze lines, which are of no clinical significance. No symptoms are associated with them, but they are incomplete defects in the enamel only. On the other hand, if they are deep-seated incomplete defects, they are called cracks. These cracks of the tooth structure, they can be of typically three distinct types based upon the locations where they occur. Okay. They can be cuspal cracks and fractures, or they can be the tooth cracks and fractures, especially in the crown segment, or they can be in the root section. Sometimes cracks originating from the root, they are called vertical root fractures. So in today's session, I shall be discussing about what are the cuspal cracks and fractures, the tooth cracks and fractures, and vertical root fractures. Firstly, we'll talk about the cuspal cracks and fractures. There is a tooth cusp, suppose. If we talk about a molar, suppose, and there is a incomplete fracture without loss of tooth structure. It is known as cuspal crack. And when there is a throughout fracture, separation of the cusp, it is known as cuspal fracture. What are the clinical manifestations of these situations? When we talk about the clinical manifestations, two set of manifestations are important to understand, that there are early manifestations and late manifestations of these cuspal cracks. Firstly, we talk about the cracks, which are the incomplete tooth structure defects extending to the enamel and dentine without any subsequent loss of tooth structure is there. Then the early manifestations, they include the most common symptom of the patient would be pain on mastication. The patient comes with a history that I have difficulty in chewing from a particular side or a particular tooth since a suitable duration, and this pain is prevalent whenever there is mastication or chewing on that side. This is a first manifestation of, I would say, crack in the tooth, crack in the cuspal. If we talk about the clinical examination in early situations, the pulp vitality of the tooth remains normal. The routine diagnostic tests like electric pulp test, the cold test, and the heat test would give no significant alterations, or they would be in the normal range. The pulp vitality would be normal. There would be no tenderness on percussion. TOP stands for tenderness on percussion. Since it is a small defect, not involving the pulp, there is no subsequent periodontitis developing, so there is no tenderness on percussion. Suppose this goes untreated. A case of a crack in the cusp goes untreated, the patient does not seek treatment, then it leads to late onset manifestations. The late onset manifestations they include sometimes there can be swelling due to continuous movement of the fracture segments. There can be loss of pulp vitality. Common diagnostic tests like electric pulp test, the heat and cold test, they can give negative results, loss of pulp vitality. And then there can be tenderness on percussion. POP becomes positive. These are the late manifestations depending upon the location and the extent of the crack in the tooth. If we talk about radiographic features, patient reports with a history of pain while chewing. There is no caries in the tooth. The tooth otherwise looks intact. There is no periodontitis. Then we have to suspect that there is some hidden crack or fracture that is going unnoticed for a long time. And depending upon the duration of that existence, it can be early onset manifestations and the late manifestations with the relevant clinical symptoms. An important feature is that radiographic features, they are absent in majority of cases. Of cracks. Whenever there are cracks in the tooth, no distinctive radiographic features can be observed. So what is the most important diagnostic criteria? Patient history. In such situations, patient history is the most important diagnostic criteria. It is the most important diagnostic criteria. You have to remember that it is the history of the patient. What are the other things? Suppose the patient history gives you a suspicion of crack in the cusp or the tooth. Then we have to perform certain objective tests. Patient history is the subjective thing. Then objective tests which are performed are staining and transillumination. Staining and transillumination means suppose there is a tooth like this with a cuspal or a tooth crack, then we can employ certain staining agents like 1% methylene blue. 1% methylene blue dye is painted onto the tooth surface and this is then rinsed off and washed with ethyl alcohol. So what would happen? This methylene blue dye would be impregnated inside the crack. It would microscopically seep inside the crack and that crack would be visible to the naked eye. Methylene blue dye has the property of penetrating these fine cracks into the tooth structure so it becomes visible to the naked eye. Another thing is transillumination. Transillumination means we use a strong fiber optic light illumination. A strong fiber optic light illumination is done. Suppose this is a tooth with a suspected crack that is not observed clinically. Then from one end of the tooth, a strong fiber optic light is shown onto the tooth structure. And while employing this transillumination test, what is important that the operatory light and the dental chair light should be shut off. So technically we would be working in a dark room. So what is done? Operatory light and chair light, they are shut off. So the only source of illumination present in the room is the fiber optic light tip that we are employing. Then what would happen when this light is shown through the tooth structure, the proximal segment of the tooth, which is toward the light source, it appears bright in color. And the distal segment of the tooth, that is beyond the crack that would appear dark because the light would not transmit through the crack present in the tooth. Why the light would not transmit, even though there is no loss of tooth structure? There is a microscopic crack in the tooth structure, but the light fails to penetrate from the proximal to the distal side. Why? What is the principle for this transillumination test? There is always fluid present in the crack. We know that the tooth is present in the oral cavity, saliva is there, other fluids are present. This fluid present in the crack, it blocks light transmission. So the part distal to the crack becomes dark and we can visualize the crack in this manner. This is known as transillumination test, staining and transillumination. Another diagnostic test that is commonly used is bite test. It is used both for cracked cusp and cracked teeth. Bite test. This bite test is done with a device that is commercially available. Two devices are available. One is Tooth Sleuth, and another similar device is a Frac Finder. Frac Finder. Okay, their devices something like this. They have got a handle. There's a pad with pyramidal surface and a central depressed area. When we look at this device from the side, it is something like this. There's a cupped out area, central depressed area. It is a plastic device, and one cusp of a tooth is tested at a time. The patient is allowed and asked to bite upon while placing the cupped area of the tooth sleuth against one of the cusp. Okay, the patient bites down. So when the patient feels pain on many a times release of pressure. Okay. The patient bites down, it is okay, but when the patient releases, there's pain. It suspects tooth crack. See, cracks are incomplete fractures, so they are difficult to diagnose. The release of pressure, there is suspicion of tooth crack. What happens due to release of pressure? There is microscopic movement of fracture segments. This causes dentinal tubular fluid movement. Okay, there would be movement of dentinal tubular fluid, and this in turn would stimulate what nerve fibers? The A delta nerve fibers. They are stimulated, and because of this, what would happen? We know that the principal sensation carried by the A delta nerve fibers is pain. So this is the basic pathophysiology of what happens whenever a frac finder or tooth sleuth is used to diagnose the cracks present in the tooth. These are the diagnostic signs. Again, you have to remember that in the initial cases, there would be hardly any radiographic changes evident in a tooth suspected of having a crack. If we talk about the treatment for such cases, treatment is generally symptomatic. Once the crack has been diagnosed, okay, if it is limited only to the enamel and dentine, non extending to the pulp, then it can be restored with a bonded restoration. What is a bonded restoration? Bonded restoration are modern composites. The crack can be slightly prepared and it can be restored with a bonded restoration is sufficient enough. If it is involving the pulp, there are chances of pulp vitality loss. There are chances of pulp necrosis. Then we have to do pulpectomy or root canal treatment, followed by some form of bonded restoration or a full coverage crown. This is the case whenever the crack or an incomplete fracture is present in a tooth, and depending upon whether it is extending to the enamel and dentine only or whether it is involving the pulp also, we have to decide upon the treatment, which is quite simple and straightforward. Okay. Another common thing is crown fractures, or we can say fractured teeth or cusps. Complete fracture is there. Loss of tooth structure has happened. These are relatively simple to diagnose because it would be visible clinically that a particular segment of the tooth has lost. So it would be visible clinically also. Okay. Crown fractures and diagnosis remains the same. We can employ staining and transillumination. We can also go for a, I would say, uh, bite test for these cases. And what about the treatment? Complete fractures. Complete fractures, the treatment at times depends upon the extent of, it depends on the extent of fracture. Okay. Most of the times, the crown fractures, they run in mesiodistal direction. Okay. The most common direction for the complete fractures of the tooth is in the mesiodistal direction. Suppose this is a tooth. Okay. This is the mesial side. This is the distal side. And when we see such a tooth from above, okay, there would be a fracture like this. The tooth would be split into buccal and the lingual half. This is known as split tooth. So the most common direction is in the mesiodistal direction. It is a split tooth, a deep-seated crack in the crown that has extended to become a fracture and completely separated the tooth into two halves as a buccal and a lingual half. So whenever this happens, the only feasible treatment is extraction of the tooth. Okay. Predisposing factors. What are the predisposing factors for a tooth to become a split tooth? Okay. They are extensive restorations. A tooth that has been heavily restored previously. Okay. A root canal treated tooth. This is more. Tooth with extensive restoration is more likely to become a split tooth than a root canal treated tooth. Okay. Heavy occlusal forces, or we can say heavy occlusal prematurities are present in the tooth. The occlusion is not balanced. There are occlusal prematurities due to which a particular tooth is subjected to a lot of masticatory load, which is not evenly distributed due to occlusal prematurities can predispose the tooth to become a split tooth. And the most favorable direction for a split tooth is in the mesiodistal direction. All the remaining features, the early manifestations, the late manifestations, and the diagnostic criteria remain the same as we have discussed with the cracks initially. When we talk about the root aspect, then important thing is vertical root fractures, VRF, okay, or vertical root fractures. Technically, vertical root fracture should not be confused with a split tooth. Vertical root fracture by definition means a complete or incomplete Longitudinally oriented defect in the tooth, defect in the root, okay, that tends to extend coronally. This is the technical definition for vertical root fracture. Suppose there is a tooth with a root like this, and there is an origin of a crack in the root that tends to extend coronally. This can be either complete or incomplete. When it is complete, it is called fracture. When it is incomplete, it is called crack, that we already know. So, something that is originating in the crown is called a split tooth. Something that is originating in the root and progressing upward is called a vertical root fracture. Since it is originating in the root, these are one of the most challenging conditions to diagnose clinically or radiographically. If we talk about etiology, etiology of what? Of vertical root fractures, then root canal treatment is the most common etiology for vertical root fractures. A tooth that has been treated endodontically, because we do root canal preparation, enlargement is done of the root canal, it compromises the dentine support of the root. So RCT is the most common etiology of vertical root fractures. It also occurs in non-RCT treated teeth. It is not that only the RCT treated tooth would undergo VRF, but the most common etiology is root canal treated tooth. The groups of teeth, certain teeth in the oral cavity are more likely to develop vertical root fractures as compared to other teeth due to the anatomical location, their anatomy, and the masticatory load that they bear. What are the groups of teeth? They are the maxillary and mandibular premolars. Okay. The mesial roots of mandibular molars, the mesiobuccal roots of maxillary molars, and your mandibular incisors. These are the groups of teeth which most frequently report the incidence of vertical root fractures. Okay. There are certain anatomical factors which predispose the teeth to occurrence of VRF. What are the anatomical factors that predispose a particular tooth to VRF? Firstly, the root cross section. From the knowledge of dental anatomy, you must be knowing that the roots of the teeth can have either round, oval, or triangular in cross section. Okay, root cross section of different teeth can be round, oval, or triangular in cross section. Different groups of teeth can have roots which can be either round, oval, or triangular in cross section. The incidence of vertical root fracture is maximum with teeth with oval cross section of the root. Okay, and the most common direction, a VRF can originate from anywhere in the root and can spread in any direction. But the most common direction for VRF to occur is colingual direction. What is the most common direction for a split tooth to occur? It is in a mesiodistal direction that is visible clinically in the crown of the tooth. And the most common direction for a VRF to occur is procolingual direction. Okay, this is an important difference from this. Okay. If we talk about the diagnosis, then it is definitely difficult. Initial stages, there are hardly any symptoms except for dull pain on mastication. So you can see that these symptoms can be confusing and overlapping with the incidence of a cracked cusp or cracked tooth. VRF also gives dull pain on mastication. But an important difference, if we take the history of the patient carefully, is that the patient would report with dull pain, less severe pain in cases of VRF, and it would be a sharp pain in cases of cracked teeth or cracked cusp. So, difference is dull and sharp pain because the corneal tooth is free to move, the root is embedded inside the bone, so it is not moving too much. The patient reports only dull pain, but these are in the initial stages. Okay. There would be positive pulp vitality. No changes. Pulp vitality response would be positive in the initial stages. Okay. POP would be negative in the initial stages, just like the cases of initial manifestations of cracked teeth. Bone loss, there would be restricted. So, the initial stages of VRF are really one of the most challenging clinical situations to diagnose. Radiographic signs, they are absent. There would be no radiographic change to appreciate on the radiographs that can suspect a VRF. So, they are one of the most challenging things to diagnose in the initial stages. Later stages, when the vertical root fracture extends more coronally and pulpally, there would be changes like extensive bone loss around the root. Okay, radiographically, we would see what would be the radiographic feature of this extensive bone loss around the root. We would see a halo defect. Radiographic halo is characteristic of your vertical root fracture. What is a halo? Halo is basically a combined periapical and periradicular pathology. I would say radiolucency. Combined periapical and periradicular radiolucency is called radiographic halo. When we study radiograph of a tooth, the bone loss or the pathology can be seen in three distinct patterns. This is known as periapical lesion. A lesion like this is called periradicular lesion, and a combined lesion, periapical and periradicular, like this is called a halo. It circumscribes the apical one third of the root, extending to the periapical tissues. This halo develops in the later stages of vertical root fracture and it is characteristic of VRF, radiographic halo. Another radiographic sign that is present is J-shape lesion. There's a J-type lesion. What is a J-type lesion? Suppose we take radiograph of a tooth suspected of having a VRF. Then along one of the roots, we would see that there is a radiolucency or a pathology with unequal arms. Okay, the pathology is extending like this. This is known as J-type lesion. This is also diagnostic of vertical root fracture. Suppose the vertical root fracture goes undetected initially or during the course of treatment, and whatever symptoms are there in the later stages, like loss of pulp vitality and tenderness on percussion, and we say that this tooth requires a root canal treatment and a RCT has been done. In majority of the instances, because radiographically hardly any changes would be there and the symptoms would be just similar to cases of irreversible pulpitis, and a root canal treatment has been done in a tooth with VRF, or subsequent to root canal a VRF has developed, then what would be seen radiographically after doing the root canal? Then after RCT, a tooth with VRF, it can show a radiographic change called cement trail on radiograph. Okay. There is a radio change called cement trail on the radiograph. What is cement trail? There is a post-obturation radiograph of a tooth. Suppose there is a tooth which has been successfully root canal treated, and there is a radio opaque filling that is visible. Isn't it? This is how we see the post-obturation radio opaque. And then we notice that initially there was nothing, but in a post-obturation radiograph, there is a thin radio opaque line. There's a thin radio opaque line extending from the root canal toward outside surface. This is known as cement trail. What has actually happened? There has been an undetected vertical root fracture. Root canal has been done, and when the obturation was being done, the sealer has been pushed through the vertical defect and it cast a radio opaque line on the radiograph. This is known as cement trail. So these are the three distinct features that can be observed on a radiograph and can give rise to the suspicion or diagnosis of vertical root fracture. The most important one is radiographic halo. Then there can be a J-type lesion, and then in some post-obturation cases, there can be a cement trail, radio opaque cement trail visible. Okay. What are the clinical manifestations? Can there be certain signs and symptoms which can help us in diagnosing VRF? Clinical manifestations. An important clinical manifestation is a narrow and isolated periodontal pocket. Narrow, isolated periodontal pocket. Okay. We know that periodontal pockets mostly develop whenever there are periodontitis, inflammation of the periodontium is there, and it usually involves multiple teeth whenever there is a patient of periodontitis. But on the contrary, we are examining a patient and one particular tooth is showing narrow. Narrow means very constricted, and isolated means not related to the general periodontal condition. Periodontal pocket gives rise to the suspicion of VRF. Okay, so there is a tooth with a root like this, and when we probe the gingiva all around the tooth, there is a narrow and isolated pocket. This narrow and isolated periodontal pocket on unusual surfaces. What are the most common surfaces for pockets to develop? Definitely they are the mesial and distal or the proximal surfaces. On the contrary, when we are examining a patient with a narrow and isolated periodontal pocket, that is on unusual surfaces like buccal and lingual surfaces. Okay, the possible reason can be vertical root fracture in majority of the cases. Okay, and these narrow and isolated parental pockets on buccal and lingual surfaces. They require flexible plastic probes, plastic periodontal probes for diagnosis. Another difference from the parental pockets. Regular parental pockets are wide enough that a rigid metal probe can be inserted, like Miller's probe that we routinely use. But for cases of VRF pockets, which are narrow and isolated, we require flexible plastic probes so they can penetrate into the deep and narrow pockets easily. This is another diagnostic criteria. There is a case of vertical root fracture with development of narrow isolated parental pockets, which has progressed and leads to a tooth with multiple sinus tracts. Usually, whenever a periapical lesion develops in a tooth, the endodontic pathology is extended to the periapex. There would be a single sinus tract in majority of the cases. But on the other hand, we are finding a tooth with multiple draining sinus tracts hints to the diagnosis of vertical root fracture. So these are some of the important clinical signs and criteria that we see in cases of vertical root fracture. Now, if we talk about radiographic diagnosis, which we have already seen, the important signs, the halo, the J-type lesion, and the cement trail, then what technique of radiograph is most favorable in diagnosing vertical root fracture? The most relevant technique is the modern CBCT imaging for vertical root fractures. Okay. CBCT imaging has an imaging unit of, we know that cone beam volumetric tomography, voxel. Okay. Voxel. And theoretically, fractures twice the size of voxel can be seen. Vertical root fractures, which are twice the size of the voxel, can be seen. Okay, the smallest voxel size is 0.0175 millimeters. This is the smallest voxel size. If we multiply it by 2, we get 0.15 millimeters. So 0.15 millimeters to 0.2 millimeters. This is the smallest size of vertical root fracture that can be seen with any radiographic technique currently available. Okay. This is the smallest detectable VRF on radiograph. So what is the principle? We have to choose a CBCT machine which has a very low voxel size to be able to diagnose even the thinnest of the vertical root fractures. Now, CBCT machines, all of you must be knowing that they obtain the images of any tissue into three planes, that is sagittal plane of section. Sagittal means it would be like this. Coronal plane of section. Coronal means imaging like this. Sagittal is imaging like this. Coronal is imaging like this. And the third plane is axial section. Axial section is like this, perpendicular to the long axis. Out of the three planes of section, the axial section is most useful for detection of VRF. Okay, which section is most useful? Axial section is most useful. Another important thing about CBCT machines is that I do not know how much knowledge you guys have about the operating of the CBCT machines, but you can remember that in the market currently there are two type of CBCT machines are available that either work with flat panel detectors or machines which work with image intensifier systems. I am talking about the different radiographic techniques which are useful for diagnosing vertical root fracture. The most useful technique would be the contemporary CBCT technique. In that, we have to look for the voxel size, VRF. Twice the voxel size can be detected. Machines with axial sectioning, plane of section are most useful for detection of VRF. And technically, there are two type of machines with flat panel detectors and with image intensifier systems. Out of the two, the flat panel detector ones, they are more accurate for VRF diagnosis. Okay. But no technique is 100% accurate. There is no radiographic technique that can 100% diagnose VRF. So suppose we are suspecting a case of VRF, what is the definite diagnosis? If we have to establish, yes, this tooth has a VRF or not, definite diagnosis would be exploratory surgery. We have to perform surgery to expose the root and examine it under microscope. Exploratory surgery is the definite thing that can be done. These are the different aspects of VRF that we have to see clinically. Okay. Now, what are the treatment modalities for VRF? Technically speaking, there is no treatment. Once a tooth has been confirmed of having a diagnosis of VRF, then extraction has to be done. Okay. There have been some empirical treatments. Empirical treatments like intentional removal of the tooth, okay, bonding of the fracture segments, we bond the VRF segments with a suitable material, replant the tooth, and splint it. But these are all experimental methods, not documented for the long-term clinical survival. These are empirical and experimental. The only possible way of relieving the patient's symptoms and preventing further bone loss would be extraction of the tooth. Okay. These are fractures known as vertical root fractures. There are different diagnostic, clinical, and radiographic signs present, and their predisposing factors, the root anatomy, etc. Okay. So this is all about the cracks and fractures which are relevant from the clinical standpoint and for your examinations. With this, I conclude today's session. See you next time with another interesting topic related to the subject of cons and endo. Till then, I wish you all a very good reading. Take care, all of you, and happy Holi to everyone. Thank you very much for being connected with me. See you. With this, I'm signing off.